Hi, good afternoon, everybody, or morning. Depends what time you're watching this, I guess. I know this isn't live, so it's always complicated, but welcome to the Fellows Tours course. I'm going to talk to you today a little bit about tours, including good decision making and regrets that I've had. So I want you to appreciate that this is a real world type of scenario, and I'm just going to walk you through a couple of cases to see kind of, let you get some sense of how I'm thinking about these things. So these are my disclosures. And I just want to start off by saying how I frame this decision, because really it's important to understand where you're coming from and to kind of develop a sense in your own head of how you want to create a framework that surrounds your decisions. The top priority for every single one of these patients should be survival, unless there's something more specific that's been stated. Functional outcome obviously is very important, but it comes second to survival. So as you're thinking about the decisions for how to treat patients with oropharyngeal cancer, you really want to put them into that order. I'm not going to get into any of the details at this point of how we generally make decisions. I know that Neil and a few other people in the previous talks have had a little more of a thorough discussion about this, but I just want to make it very clear that a lot of decision making goes into figuring out which patients you should be doing surgery on. It would be wrong to make the assumption that showing up in the operating room is step number one. A lot of thought goes into it. Everything from how you think about the patient's medical conditions to what you're going to find in the operating room, to obviously a very thorough understanding of the outcomes data that you feel like you should be paying attention to. So that being said, I'm going to kind of just jump right in and look at a few cases. So this is case number one. This is a 64-year-old male who was referred to you by a primary otolaryngologist for a right neck mass. A needle biopsy of the neck node showed HPV-related squamous cell carcinoma. The patient is a non-smoker with no significant medical history. He brings with him an MRI that shows a primary lesion of the tonsil, as well as a PET scan, which shows the tonsil as well as two neck lymph nodes and no other significant findings. You meet the patient in the office. He's a relatively thin patient with good mandibular anatomy. You have him open his mouth. He's got very little gag reflex. You have a good feel and a look at the tonsil area, and you think, gosh, this is a pretty straightforward surgery. His nodes aren't that complicated. Really a great example of someone who I could take to the operating room and do a robotic surgery on. The patient was told all about you, how great of a doctor you are, how amazing you are at doing tours. And so you're thinking, maybe I should just get this guy right to the operating room. And it just so happens that you have space on your robot schedule, which if you're anything like me, that's not always that straightforward. And this becomes relevant, frankly. I mean, there's a lot of times when, depending on the institution that you're in, depending on the forces that are in place in your operating room, there might be limited time on the schedule or limited robot access time. So these things might become relevant to help reduce delays. Maybe you know where I'm getting with on this, but we'll see. So these are the MRI and the PET scan that you're seeing here. Again, you can kind of see on the PET scan the primary, which doesn't look too big. On the MRI, you don't see any unfavorable characteristics. The nodes don't look too big. The primary looks pretty small. So you figure what could possibly go wrong. So I decided to go right to the operating room with this patient. And when I say that, what I mean is that I skipped over a step that I think is probably important, which I'll get to in a minute, which is an endoscopy. Got into the operating room, started doing the tonsil surgery, and frankly, pretty immediately after kind of taking a good look and a feel, I realized that there was a much higher level of submucosal involvement at the level of the palate than what I had expected. Despite the relatively straightforward exam in the office, or at least what I thought was a straightforward exam, it turned out that there was more submucosal involvement. So what did I learn in this case? Well, frankly, the case ultimately went fine. I ended up doing a buccal fat flap, but I really believe that pretty much with very few exceptions, you should always consider doing a direct laryngoscopy on these patients. It is actually part of the rationale for why surgeons are an important decision maker part of the oropharyngeal cancer evaluation. You need to also understand your reconstructive options so that you're not stuck with a palatal defect. And on the flip side, I would also say that there are patients that you look at in the office who have very large lesions, like in their tonsil or base of tongue. But once you get them to the operating room, you all of a sudden realize that they are surgical candidates. So I think this can go both directions. And again, I really emphasize the need for a direct laryngoscopy on pretty much every patient. All right, second case is a 61-year-old male, non-smoker with a history of atrial fibrillation. He is on a Plavix and aspirin. Diagnosed with a new neck right mass, and a needle biopsy is consistent with a squamous cell carcinoma. It was also P16 positive. Preoperative scanning as well as PET scan and your exam really don't show any primary lesion. These are the scans. You can see the MRI and the PET scan, really no obvious primary lesion. We reviewed this in tumor board as we always do. So I took the patient to the operating room for an unknown primary TORS. And I don't have time in this talk to get into the details of what unknown primary TORS looks like in our hands, but it looks similar to, I assume, what it looks like at many institutions, meaning we start with a thorough endoscopy. We then sequentially move through different body parts, including the tonsils and then the base of tongue. It's important to realize in a case like this, and this is a specific patient, I had to take him off of the Plavix and the aspirin. His cardiologist was somewhat reluctant to have us do that because he was considered high risk. He'd actually had previous DVT, and of course the AFib. And so in some ways I wanted to kind of get everything done at once if I could. And I know there are some people in some places that routinely stage some of these procedures, including the TORS with a neck dissection, but I tend to do these procedures all as a single bundle. So my hope was to kind of get this all done at once. So what we discovered upon getting into the base of tongue was that despite the fact that this lesion was not tremendously visible either on exam or on his scans, there was actually a pretty significant amount of base of tongue involvement at the submucosal level. And this surgery turned into a long surgery with extension of this lesion from the base of tongue laterally onto the glossotonsillar sulcus and all the way into the piriform sinus. I think I probably sent 3 or 4 separate sets of frozen sections on this patient, only at the end to barely get around this tumor, with a relatively large resection, despite the fact that he started as an unknown primary. So what did this teach me? First of all, if I had known that this lesion was so big and so complicated, I probably would not have agreed to do a transoral robotic surgery. The size of the defect, the close margins, the fact that I didn't feel confident about my margins all led me to make a recommendation of postoperative chemoradiation in this patient. So I think even though it is unclear what the role of negative margins are in terms of patient outcomes, what is clear is that if you get positive margins in most institutions, you will still end up having a patient that gets chemotherapy and radiation on top of your TORS. And that is clearly a separate and very controversial topic in and of itself, but I'll tell you that that wasn't clearly the goal of me taking an unknown primary patient to the operating room. So from my perspective, understanding that it is reasonable to consider aborting an unknown primary surgical approach or staging the unknown primary part and the resection if you find a primary lesion. So something to consider. The final case I'll discuss is a 55-year-old female with a newly diagnosed tonsil cancer. You've taken her to the operating room, you did your direct laryngoscopy with biopsy, she's had a PET scan, a CAT scan, and this appears to be a T1N1. And when I say N1, I'm talking about the AJCC7N1, meaning a single node under 3 centimeters. And then here comes the big but, which is a retropharyngeal carotid artery. And this is the CAT scan. You can see on the right side of the screen here, not a tremendous amount of blush, but I have my pointers on it. This pretty medialized retropharyngeal carotid that you can see kind of going back up and down in the field. So pretty sizable vessel right underneath the primary, and you see a single small node. So What do we do here? So if this was a live presentation, I would ask you these questions. How do we treat this patient? She's a T1N1, very high chance of cure, stage 1 cancer that's HPV related, in case I forgot to mention it. Radiation alone, maybe surgery. And so I think there's a lot of things that you should be considering in a patient like this, including where they will be getting their treatment. Because if this patient was getting treated outside of an academic institution, they'd probably be getting high dose chemoradiation. And then, of course, patient preference always comes into play. So we actually ended up doing surgery on this patient, which I guess I would say isn't a lesson so much as a maybe interesting case, but we did surgery for her. Her ultimate stage ended up being a T1N1. We did do a free flap, which required also a tracheostomy. And I can imagine that is somewhat controversial, but this is what that patient wanted. This is what we have demonstrated to have excellent outcomes. And the patient literally avoided the need for any radiation and any chemotherapy. So I think that's all the time that I have today. And I really appreciate your paying attention. I hope you learned something. And I hope to have a chance to interact with more of you in the coming years. And good luck in your fellowship endeavors. And thanks again, and take care. All right.